We might start with the slides. Thank you, Roisin, that's perfect. So as I said, you're very welcome. Thank you for joining us today. And we are going to start the session now. So the session is being recorded and will be available on our website. So for any of your colleagues that aren't here today that couldn't make it, it will be available for you to share within your organization, within your teams and services. We've disabled the chat function today because we're expecting a high volume of people attending the webinar. But as ever, we encourage you to get in contact with our team by contacting opendisclosure.office@hse.ie. From our side, we will be putting in the chat the means of dialing in. Should you have any challenges with technology, you can dial in and listen to the audio in any case. As ever with our webinars, you will be in, you can claim some CPD points. So you can email again our team at opendisclosure.office@hse.ie and confirm your attendance, and we will send you a certificate so that you can claim those CPD points. We are delighted to have our ISL interpreters with us today, Lisa and Ella. They'll be providing Irish Sign Language of interpretation for the webinar today. If you are unable to see interpreters in your main view, please scroll over and click on the 3 little dots over the video and click on to move to stage. In addition, closed captions are available to you. This is text that will appear on your screen to reflect what is being said by the presenter during the webinar. To enable this function on your device, you see the little icon there that you just click on, okay? We are delighted to be joined today for the launch and to give their views and thoughts around the revised open disclosure policy by Bernie O'Reilly. Bernie is the chair of the Irish group Patients for Patient Safety Ireland. She has been a champion for open disclosure and has worked with us closely over the years and has given very generously to the health service in her time and sharing her experience and her family's experience. And she's also given her forward to the policy. So we're thrilled that she is again giving us time this morning to speak about the policy. We're also joined by Dr. Colm Henry, who's our Chief Clinical Officer within the HSE, who I'm sure you'll all be very familiar with, who really takes on the leadership role in terms of quality and safety within the organisation and working collaboratively with the senior leadership team in that area. And we're joined also by Dr. Orla Healy, National Clinical Lead for HSE National Quality and Patient Safety, who's really been spearheading this piece of work and chairs the National Open Disclosure Committee. So in the first instance, we actually have Bernie, who's going to give us her view and some thoughts around open disclosure.
Thank you, Lorraine, and thank you for this opportunity this morning. So I've been following the path of open disclosure for 10 years. I've understood the need for it for close to 20, and it's been a core interest for me and other members of Patients for Patient Safety since 2013. And our group has remained a collaborative partner throughout that time. The HSE Open Disclosure policy being launched today sits hand in hand with the Department of Health's Open Disclosure Framework, and together they are guidance for healthcare staff delivering information to patients and families following adverse incidents. We've got lots of guidelines to steer us, laws to live by, but the biggest deciding factor in each one of us is our own moral compass. That compass points us in the right direction, and most of the time, but faced with a challenge, perhaps sometimes there's a pause. When questioning the right thing to do, the first person we have to be truthful with is ourselves. If open disclosure was easy, we wouldn't need encouragement, legislation and help to do it. Open disclosure is set against the backdrop of human challenges. No healthcare person sets out to be involved in a patient adverse incident any more than a patient does. But what happens in the aftermath rests with those who have the facts and therefore the responsibility to disclose. Many people apply honesty spontaneously. Others are influenced by the people around them, and those influences need to uphold being truthful. Applying honesty requires self-conviction, strong support from colleagues, good example from leadership, coupled with training. That training applies to everyone, because everyone creates the culture that exists in an organisation, and culture is defined as how an organisation performs when no one is looking. The standards we walk past are the standards we accept. So if we ignore what we know to be wrong, we are enabling it. Training needs to be more than online training, because you have to practice communication skills to become confident engaging in disclosure conversations. Most healthcare skills are built on the apprenticeship model, learning by doing, the student under the tutorship of skilled elders, masters, mentors, who in turn must lead by example. Patients rely on receiving person-centred care from trustworthy people throughout each healthcare engagement. I used to only see open disclosure through my own lens, the family looking for answers following the death of a loved one, needing the truth so that we can understand and navigate changed lives. With the passage of time, I do understand human factors, but I still go back to what is the right thing to do, and honesty trumps every time. So all the supports to back that up must be applied. Reading page 81 of the policy being launched today made me hope we've moved forward. Satar et al. In 2020 found that there is a difference in attitudes and expectations between patients and healthcare professionals. Regarding the disclosure conversation, patients and family members expressed a need for information, the importance of a sincere apology and a promise of improvement. However, healthcare professionals face several barriers which hindered appropriate disclosure practices. These included difficulty of disclosure in a blame culture, avoidance of litigation, lack of skills on how to conduct disclosure, and inconsistent guidance. We cannot allow honesty to be trapped by fear, lack of skills on how to have open conversations, and inconsistent guidelines. The words in this policy are the guidance and must direct everyday actions for all. Progress must be measured, so audit is necessary, and not just number crunching, getting the true picture and fix the areas that need fixing. Capture people's experience of open disclosure since the enactment of the Patient Safety Act, Notifiable Incidents and Open Disclosure 2023. Ask patients, ask staff, do you feel supported to have honest conversations with patients? What worked well? What could be done better? Do colleagues advocate for honesty and support each other in times of challenge? Do peers and those respected as leaders uphold standards for others to emulate? Use staff surveys to gauge what's happening. Ask patients and families, did they experience better conversations, the small bedside apologies, plus the more difficult formal open disclosure experiences? Do they need improvement? Are patients and families even aware of what open disclosure means? Add in some questions into the patient experience surveys. Use the information from your service, your say, that patient advocacy service, NIMS, build in more intelligence to extract all that information. It's essential to measure to get a handle on the progress or lack of. Incident reviews are part of incident management, and there's always a little bit of hesitancy around in-house reviews. That's not a negative comment levelled at the HSE. You hear it directed at all state services. If people are still left with unanswered questions following HSE reviews and where the process has reached its end, there needs to be a clear pathway to another level of oversight. I know the Ombudsman has a function, but perhaps we just need something else. Mediation is lacking in our health service. It's another channel to explore. On that subject, I'm particularly pleased to see so much in this policy about supporting people, patients and staff. The designated person is such an important role. Done well, it's a stent in what used to be a blockage for patients and families. The wall of silence now has a door. I absolutely welcome the role because harmed people should not be abandoned to navigate a system they have been plunged into unexpectedly. There will be occasions when the pairing of patient or family member and a designated person results in a mismatch. It's nobody's fault. It just happens. People don't always bond and to the level of trust that you need to be bonding in these roles. So speedy recognition and a reassignment saves further trauma. I truly hope this role finds its place, that those who undertake it are well supported by training and given the time to do the job well, and that their facilitation of communication is enabled from within services and embraced by patients and families, and that it makes that all-important difference. I also hope it will be scoped out beyond Category 1 notifiable instance, and that Category 2 instance will also be included. No person who requires the service should be denied it. Categorising harm is subjective and in the hands of people other than the person who's been actually harmed. So in the name of person-centred care, I hope this role is expanded. Someone in our patient-to-patient safety commented yesterday that litigation takes years. Timely intervention at the early stages of harm would likely take considerably less and be time well spent. I am pleased to see that people will be made aware of the patient advocacy service. It's an absolutely brilliant service from a patient and family point of view. Introducing the patient advocacy service to patients is another display of openness and acknowledgement that services wish to make it easier for people to express their feedback when things haven't gone well. Again, there needs to be an escalation point when the patient advocacy service has gone as far as it can go and there is still no resolution. Find the least arduous means. Advancing to litigation is awfully wearing on everyone. Our legal system is protracted and way behind other countries in terms of bringing speedy resolution to cases. It's burdensome on patients and healthcare workers alike. The HSE's biggest asset is its staff. Nothing happens without them. They are the vessels of patient care and advocacy, and their well-being is really important. Adverse patient incidents weigh heavily on staff. I've heard too many accounts of staff not being adequately supported when traumatic events have unfolded, and I sense there is a lot more work to be done in this area. The success of the Open Disclosure Policy 2025 rests with the choices people make in the wake of an incident. Humans have to action this policy in everyday events. Nothing happens without the will, effort, and belief. So I'll ask you all, do you believe in honesty? Are you willing to make the effort to deliver it? If the answer is yes, I truly believe this policy will deliver. I want to thank all those people who have driven open disclosure forward from the earliest days right up to today and encourage everyone to continue. And I look forward to words becoming actions and that we will get to witness true open disclosure. Thank you.
Thank you, Bernie. That was very powerful as always, and it's no surprise that we ask you to present on the session this morning. You touched on some very important topics and the complexities around open disclosure, and I know that you're a big champion of the designated person role. I think a lot of people dialing in today will be familiar with it, but I suppose from your perspective, what do you see the importance of the designated person role and in what they do?
I suppose when I reflect back to my own situation, after my husband died, there was no one point of contact, and I wasn't aware of anything. I had never heard of incident reviews. I didn't know what was available to me. I mean, I didn't even have access to bereavement counselling within the hospital, even though I know that I found out later there was actually a service. So that when you've been like, you're shocked to your core after an incident, so you need that person who understands the system that you're going to have to engage with. So it's that two-way channel. It's not practical for you to be able to gain access to the consultant or the immediate people that you might have been working with on an ongoing basis, or that were involved in the incident on an ongoing basis. So that person who knows the system at the hospital has made a connection with you, that you now hopefully trust each other. That's that go-between person, and that liaison piece is just massively important. And I think it's a new role. It's going to take a while to bed in. But I think when it gets up and running, I just totally believe in that function. From my earliest conversations, I can distinctly remember talking to Angela Teisel, probably the first time I ever met her, and I said no one should be abandoned to a system that they don't understand. So it's really, I've just got great hopes for it, and I just, I really have. I think it's an excellent addition to person-centered care, family care, staff care, because it's going to be a two-way. It's a two-way exchange, so I think it's going to be good.
Yeah, I think I totally agree with you. It's something that's obviously required for legal purposes for the small cluster of incidents, notifiable incidents in the Patient Safety Act and the policy, sees it as a requirement for all Category 1 incidents, and we would like to expand that, like you touched on. Some operational challenges in terms of resources, but I think just what you described today in terms of how important and how key that role is for that ongoing communication with patients, which is an area that we know we fall down on time and time again. So it's a really important point. Thank you, Bernie, and thank you for being with us this morning. I'm going to hand over to Dr. Colm Henry now to give his thoughts on open disclosure and the policy. Thank you.
Thanks, Lorraine. Can you hear me okay?
Yes, thank you.
Yeah, so I'd like to thank Bernie, as always, for her enthusiasm and her loyalty to this issue, and her inspirational words, as always. So thank you, Bernie. So I'm here today as Chief Clinical Officer of the HSE. I'm delighted to help launch this disclosure policy for 2025. It's a revision of the 2019 Open Disclosure Policy, so there's significant learning there. It represents a lot of engagement. It represents much legislative change over the past few years and sets out, with I hope clarity and purpose, what we owe to patients and families when things go wrong. What we owe them is the truth, and the truth, not just the truth in its literal sense, but truth delivered with empathy. So this is a policy launch today, another milestone in our ongoing work to address that issue of culture that Bernie raised. And we want to create and embed in that culture transparency, compassion, and of course what we call patient-centered care, not only as something we aspire to and aim towards, but something that's embedded in all our operations across all the services, hospitals, primary care, community care, mental health, disability, older people, screening, ambulance service. The open disclosure policy applies equally to every setting where care is delivered and where harm, which unfortunately can happen anywhere where harm occurs. So today's launch is much more than the release of a document. It's a clear signal to all our staff, wherever they may be in all those services, to patients, wherever they may present, and to the public, that the HSE is committed to openness, even when it's uncomfortable, and they were willing to confront some of what are perhaps the most difficult moments in healthcare with honesty and compassion. Of course, open disclosure, this is, I said, is a milestone. It's not new in the HSE, but this policy brings a further embedding or depth to its consistency in applications. It tells families, patients, what they have a right to know about in healthcare. It moves beyond what was a traditional stance of silence or defensiveness, and instead it offers a more open alternative of empathy, explanation, and a sincere apology. And it's fundamentally about trust. It reflects what should be our collective commitment to care for people, not only in the context of their physical or mental illness, but also to care for people in the way we communicate with them and acknowledge when things go wrong. And a system as complicated as ours, with 140,000 employees, many diverse settings, things will go wrong. And it's important that when things go wrong, we don't corrode trust any further, but we help rebuild it from the very beginning. So what this policy sets out are roles and responsibilities at every level of the system, front line of healthcare to the boardroom. It's a collective responsibility wherever one works, whether it's HSE Stevens Hospital, whether it's an emergency department, whether it's a mental health facility, whether it's a national ambulance service. And Bernie alluded to this new role, which is being formalised now, required by the Department of Health's 2023 Open Disclosure Framework. And that's of the Open Disclosure Clinical Managerial Champions. And these champions are not just figureheads, they're leaders and go-to people who guide, support all our healthcare professionals, all our colleagues on the best practice in disclosure. And clinical leadership is particularly important here. As clinicians, we lead through our technical expertise and our knowledge expertise, which patients expect from us, but also how we respond when that expertise translates into treatments that don't go well and may result in adverse events. And our words and actions and how we respond at that time set the tone for those around us. If we speak openly about harm, if we acknowledge errors with sincerity, if we prioritize people, our teams will follow our behaviours. And that again goes back to Bernie's point about culture. It involves leadership in every setting and setting example. It must be visible. I mentioned frontline, but it must be visible in all leadership forums. Anyone who's in senior leadership with the responsibility and obligation to practice the principles of open disclosure every day. And this means creating an environment of work where concerns can be raised without fear. It means ensuring that open disclosure is embedded in our governance frameworks, all our reports, all our response mechanisms, and it means by leading by example. So when we discuss, for example, instance or serious incident executive meetings, we shouldn't just ask what happened, why it happened, but also, was this communicated to patients and their family? Were the staff supported? What have we learned? Certainly my experience from champions of open disclosure, such as Deirdre Madden, who led the previous QPS committee in the HSE, was when we discuss incidents with those of national significance, the first questions asked were patients told, were staff supported, or families being supported? And this is where this national quality and patient safety function led by ORA plays such a pivotal role through programs like QPS Incident Management, Patient Safety Together, the National Centre for Clinical Audit. These different platforms give expression and visibility to the way patients feedback to us through learning from incidents, and it links open disclosure to broader safety and quality goals. These different entities within our national QPS provide tools, information that enable leaders to drive accountability and learning across the system. And Orla will be speaking after me today and will elaborate on this further. Over my years as Chief Clinical Officer and as a clinician for many years before that, I've experienced directly firsthand how difficult open disclosure can be. And I've lived through times when we didn't have open disclosure and there was that that defensiveness and silence that I spoke about earlier. And I know that and all of you know that when harm happens in healthcare, it can have a devastating impact on patients and families. But healthcare workers also who set out to work every day trying to make people better also experience suffering in these circumstances. And what's consistent and clear to me is that the way we respond when harm happens has a profound influence on the ability of everyone to recover and resolve. When we respond with honesty and humility, the space between patient and provider becomes one of shared humanity and not one of division. That isn't to say open disclosure is easy. It's not easy, but it's also right. And I believe this policy will make it easier for patients, families and staff by providing clarity, structure, the roles we refer to, and above all support. So to conclude, I'm proud to formally launch this policy today. Let's not call it a tool or process, but a way of building and rebuilding trust. Let's not look at it as a resource in incident management, but as a core trait of leadership, wherever leadership may be. And let's look at open disclosure as a key element in building trust with patients through transparency. And let's all show through our actions what safe, ethical, and patient-centered care really means. Thank you.
Thank you, Colin, and you've hit on a number of really important topics there, in particular around leadership. And obviously, you as Chief Clinical Officer have a key role in terms of that clinical leadership. And as part of the senior leadership team, I know even that group of our leaders have asked for assurances around open disclosure, which I think kind of aligns with the whole system-wide approach to it and the aim of embedding the policy. What role does leadership play in modelling effective open disclosure in your view?
Well, leadership, as I mentioned, Lorraine, happens in every setting. And I will go back to what Bernie said about culture. And the culture of an organisation is set by leaders, wherever they may be. And a leader can be a leader, at its crudest definition, is someone who has followers. And it follows, if you accept that definition, a leader can set per example, and followers will take from that example. And perhaps the most powerful leaders are those mentors we had when we were either junior doctors or nurses or healthcare professionals, those who were more senior to us and to whom we reported. The tone they set in responding to incidents, in not referring to open disclosure as something that has to be done or something imposed upon them by others, but something they embrace and practice, will be critical. So I'm very aware of the limits of what we can do in the centre of the HSE in national leadership positions. The leadership, we can set a certain tone, we can communicate on days like this, but the leadership set at the front line by people who are mentors to staff in training will be critical in creating that culture that Bernie talked about.
That's really helpful. Thank you, Colin. And as outlined, I will now hand over to Dr. Orla Healy, our National Clinical Lead for NQPS.
Thank you, Lorraine, and thank you, Colin, and of course, thank you, Bernie, as always. And I'd like to extend my thanks to all of you for joining us this morning, and to the entire Open Disclosure team and colleagues on the Open Disclosure Steering Committee. It is my pleasure to be with you this morning as we officially launch our 2025 Open Disclosure Policy. And this marks a significant step forward in our collective journey to ensure that honesty, empathy, and learning are at the core of how we respond when things go wrong in healthcare. And they do go wrong in healthcare. It is inevitable that things don't always go as planned. Put simply, the updated policy recognises that patients and families deserve to be told when something goes wrong. When a patient safety incident or a notifiable incident occurs, they have the right to know what happened, why it happened, and what we're doing to make sure it doesn't happen again, or to at least our best to prevent it from happening again. Patient Safety Act, known as the Notifiable Incidents and Open Disclosure Act 2023, provides a strong legal foundation for open disclosure. However, it's not just a matter of law. It's about values, it's about trust, it's about doing the right thing. So I want to emphasize that this is a whole organisation effort. Whether you're working in a hospital or in a primary care centre or in a community team or a national service, open disclosure is everyone's responsibility. And it's only through a shared commitment that we can truly embed a just, transparent and learning culture. So for the next couple of minutes, I'm going to talk about open disclosure as a pillar of incident management, how we learn and use learning for open disclosure to improve the quality and safety of our services, and our approach to assurance and standardization, strengthening the framework, and our approach to mandatory training to build that culture of capability and confidence. So open disclosure is not a standalone process. It's a critical element of our broader approach to incident management and how we respond to patient safety incidents. It complements and strengthens the incident management framework, which we're currently reviewing and aligning it with the current patient safety standards and legislation. So all of these elements are synergistic. When we speak openly about what happened in the wake of an incident, we promote transparency and responsibility, and most importantly, healing. Open disclosure of itself provides an opportunity to demonstrate compassion and to support those most impacted, patients and their loved ones, and of course our staff. That's why open disclosure is not an adjunct to incident management. It's a vital part of it embedded within the process. This policy ensures that open disclosure is not just encouraged, it's expected. It's the norm. It embeds the practice within our systems and structures. When it's conducted properly, it creates a vital feedback loop between the incident response and continuous improvement. Our National Quality and Patient Safety function through incident management plays a central role in supporting service to embed open disclosure as a standard practice as part of incident management. From designing tools and guidance to building capacity through training, our team enables safe, consistent implementation across the services. So with regard to learning, at its heart, Open disclosure is a tool for learning. The 2025 policy makes this explicit. It emphasizes that each disclosure is also an opportunity for reflection, for review, and for refinement. When we communicate openly with patients and their families, we gain insights that we might not uncover through the reviews on their own. The lived experience is invaluable. By listening to the patient's and the relative's voice, we can strengthen our understanding of what happened and why it happened. When we take that feedback seriously, it becomes a very powerful driver of change. And this is where the broader structures of the QPS function come into play, in particular our national QPS function. Through our intelligence team, we're transforming how we use incident and disclosure data, not just to respond to harm, but to anticipate risks and monitor trends and proactively improve care, linking it to our improvement programs. Our QPS Connect team and our Patient Safety Together program teams support services through shared learning, resources, and practical guidance. Colin has already mentioned these teams and the National Centre for Clinical Audit, which ensures that the insights generated through audits are acted upon and that the patient voice is captured through open disclosure is used to inform and shape wider quality improvements. Our education team delivers a range of quality and patient safety training through blended learning, simulation workshops, and some bespoke supports based on roles and settings. All of this moves us from individual accountability to collective learning, good clinical governance, helping us to develop safer processes, stronger systems, and more resilient cultures of care. I mentioned that I was going to talk about assurance and standardization and strengthening the framework. So this current 2025 policy brings a greater clarity and consistency to how open disclosure should be carried out. It aligns with the Department of Health National Open Disclosure Framework and introduces standardized processes and tools, including documentation, governance requirements, and reporting mechanisms enabled by NIMS, that's our National Incident Management System, which most of you will be familiar with. Our goal is consistency. Every patient, regardless of where they are in the system, should receive the same level of honesty and support. Equally, it provides assurance to staff. Staff must know when they engage in open disclosure that they're supported, not just by their line manager, but by the system as a whole. And this is underpinned by our national compliance reporting structure, which ensures that transparency and accountability through regular audits, as well as National Open Disclosure Annual Report, which is, of course, coordinated by Lorraine Schwanberg and the wider team. And that policy or that annual report is reviewed by the HSE senior leadership team and the HSE board, and then submitted through the CEO to the Minister for Health. So there's a very robust governance structure around all of this. I mentioned training, and the open disclosure training is mandatory, and this is critical to building that culture of capability and confidence. The cornerstone to open disclosure is confidence. Confidence in the communication, confidence in handling sensitive conversations, in knowing what to say and how to say it. This requires skill, preparation, and a very high level of emotional resilience. Any of us who's been involved in open disclosure knows how emotionally draining open disclosure is for everybody involved. To this end, we've embedded mandatory open disclosure training across all HSE and HSE funded services. This training has been designed and delivered by our National Open Disclosure Office, and it's tailored to staff roles and experience from frontline clinicians right through to senior managers. It's valuable training and it's available in a range of mediums, from online self-directed learning on HSE land to virtual seminars to full-day in-person workshops. It's not a once-off exercise. It has to be refreshed every 3 years to ensure that the knowledge remains current and that our culture of openness remains strong. And of course, we do deliver bespoke training for particular incidents and particularly challenging circumstances, and that's always available to people. So, in closing, I would like to recognise the voices that help shape this revised policy, our patients and their families, our clinical and managerial champions, our open disclosure leads and our trainers, and all of you who are committed to safer, more compassionate care. Special mention to our National Disclosure Office as part of the wider QPS incident management team. So it's Lorraine, Roisin, Kelly, Ellie, and Mary. They've led this review and the update of the policy very admirably. Policy is a foundation and one that we will build on together. Through open disclosure, we honour the trust that patients place in us. We support our staff in doing the right thing, and as we move step by step towards a health system where learning and improvement are continuous, where safety is not just an aspiration but a lived reality. Through this new policy and the wider work of the quality and patient safety function and our collective efforts, we're not only going to respond better to incidents, but we're going to build safer services for the future. Particular thanks once again to the patients and families who've supported us in this process, who have shared their valuable insights and experience from the hardest times in their lives, and particularly Bernie and her colleagues who've participated in the Open Disclosure Steering Committee. So thank you all, and I'm now going to hand back to Lorraine, who's going to take us through some of the major changes evident in the revised policy. Thank you.
Thank you, Orla. And Roisin will share the slides, but just to reflect on some of the words that you've said as well, I think you've really outlined how incident management is about learning and improvement, but it's also about the relational piece. And really, if you marry open disclosure as part of that, and if it's an integral part, that you actually get much richer learning by involving the patients and the family in the process, and as much as they want to be involved. So it's just it really enriches that learning piece. Thank you.
Thank you.
Thank you, Roisin, for sharing the slides. So the policy is obviously available. We've uploaded it to the National Central Repository, and you can peruse that. Just to give you some, I suppose, high-level takeaways just from today's webinar as well. So we might move on to the next slide. So you'll all be very familiar that the current, it's a revision from the 2019 policy. And I think we've been in a very fortunate place in Ireland in terms of some of the developments in terms of the leadership around open disclosure over the last number of years, starting with the 2013 policy. So this policy really builds on all the good work that has taken place over the number of last years and the learning that we've amassed over that time. And it still resembles a lot of some of the kind of key tenets from earlier policies. So we have incorporated learning from open disclosure and incident management experiences by those impacted, so patients, their families and staff, which is why it was so enriching that there was quite a lot of engagement as part of the consultation process. I think it's remiss to say there have been some significant national developments with regards to open disclosure that aren't just relevant for the public healthcare sector, but it's relevant across the board. So obviously we are very familiar with the requirements of the National Patient Safety Act 2023 and the National Open Disclosure Framework. And there's some other developments as well, which we've tried to incorporate into the policy, the Global Patient Safety Action Plan, and so forth. But really, within the Irish context, those two developments by the Department of Health have been key drivers to be absorbed within the revised policy. Thank you, Roisin. So we did have a public consultation. We we had started working on the revision of the policy, but we really wanted to hold back until the Patient Safety Act commenced and the launch of the National Open Disclosure Framework. So following those developments, we did hold a revised the policy and put it out for consultation. It was out for consultation over a 6-week period. That consultation was obviously cascaded through our usual channels to many groups, to many staff, to patient organisations as well, advocacy unions and so forth. And the feedback was generally very positive. It was clear and understandable. It is comprehensive. And really one of our key objectives was to put the patient at the forefront of this policy, which there was positive feedback with that regard. We got some very constructive feedback, and a huge thank you to everybody who did take the time to provide us feedback as part of that consultation process. So there were some very interesting comments, in particular around, just to give a few examples, our actual definition of open disclosure never referenced an apology specific, which when somebody points it out to you, it's a very obvious point to note. So that's been incorporated. Some very invaluable insight into some very specific scenarios, be that around some particular communication aids that some staff, patients and service users may need. There was an ask for us to be very clear on the different steps within an open disclosure process. And then there was a lot of discussion as well in terms of when or what type of incidents actually trigger open disclosure. And I'll speak to that a bit more in a few minutes. And there was some, I suppose, feedback as well, and to make this somewhat, I suppose, informative this session as well. One comment was whether it would be confusing about referencing an open disclosure framework and an open disclosure policy. So just to summarise, there is the Department of Health National Open Disclosure Framework, which is written by the Department of Health, which requires every health and social care service to have an open disclosure policy. So within the HSE, you all have an open disclosure policy, okay? And then we know that's very much adapted by other organisations as well to meet their needs. So maybe a little bit in small print here, but some of our key objectives in revising the policy was to maintain and keep the patient and their family at the forefront of it. We have incorporated a particular chapter around supports, as Bernie referenced already, and that very much includes what are the supports available to our staff as well. I've heard a number of the speakers today reference about, whilst everybody is very driven and wants to be open and transparent, it's not always easy. So we need to make sure that we support our staff in delivering on this piece. We've incorporated the national developments, the legislation. There have also been amendments to the Civil Liability Amendment Act. We've included those within the within the policy as well. We know through learning over the last number of years, and this is an international experience as well, the experience of compounded harm. So whereby somebody might be a patient or their family might be affected by a patient safety incident, but that the process then sometimes lets them down, and actually there's an experience of compounded harm. So we've tried to address that within the policy in terms of being very clear around the process and really emphasising the role, some of the key roles, in particular the designated person. We just know how invaluable those staff are to help prevent those experiences. Obviously, within the health service, a lot of change going on at the moment, in particular around sláinte care. So we've looked at the roles and responsibilities with that lens as well to try and align with that. We've again reviewed the process, a particular chapter around implementation and assurance around open disclosure, which is a really big piece for us. I know Bernie touched on audit around open disclosure, and certainly within the HSE there are a lot of developments in that area, not just around measuring whether it has been done, but what we really want to start looking at, what are the experiences for patients, service users, their families, and staff as well around the actual open disclosure, so we can constantly make improvements around that piece. We have applied the HSE PPPG guideline in terms of the policy as well. So it is comprehensive, and I suppose we've tried to hit all the requirements with regards to that. Next slide. So this is kind of layout. These are the chapters that we have included within the policy. And as with any policy, we will obviously review that in a few years. But really, we've tried to be very clear around the process, roles and responsibilities, and the supporting elements that we think is so key for delivering on open disclosure. Next slide, please. So the opening chapter is just some high-level references for you to take away. We've always had principles around open disclosure, and we've retained those. Very little change with regards to that. We talk about one of the minor changes, but it is very relevant, which stems from learning from the National Open Disclosure Framework from the department. It's not just focusing on clinical governance, but also focusing on corporate governance. Other than that, the principles we've retained as is. We've expanded our actual definition of open disclosure to reference notifiable incidents that have been introduced as part of the Patient Safety Act, and we've specifically referenced the need for an apology within the definition. We do use the term patient throughout the policy, and we know that is not quite the right term for a number of our service users, and that for the purpose of consistency within the policies. We have outlined that at the beginning. We've emphasised the importance around a just culture, in particular restorative just culture, because we know that our staff need to be supported, need to be treated fairly and just when a patient safety incident occurs, so that there aren't any kind of barriers in place around that might hinder open disclosure. And we've emphasised that it's not just around a culture of openness and transparency, but it's a culture of openness, transparency, and learning. Section 2 of the policy, chapter 2, is in particular just, I suppose, just summarising kind of key drivers for open disclosure. So you'll often hear us within the national office and amongst your own communities talking about open disclosure being the right thing to do. There's obviously the policy requirement, not just obviously our own HSE Open Disclosure policy, but that's very much stemming from the Department of Health National Open Disclosure Framework as well. There's a professional requirement, so a lot of our professional regulators will have that reference in their code of ethics now as well. There's regulatory standards in terms of HICWA and or other, I suppose, healthcare regulators as well, who have a role in ensuring that open disclosure is part and parcel of our practice, and certainly it's an area that they will be particularly honing in on over the next little while as part of their inspections, and that we know that already. And then there's obviously the legal obligation that has been introduced as part of the Patient Safety Act for that subset of incidents called notifiable incidents. And we have some nice graphs within the policy that will hopefully help you with regards to that as well. Okay. The roles and responsibilities sections is quite an expanded section, and there are a number of key roles that have been introduced, some that aren't new at all. So the designated person role is not new. It's something that's been sought after for a number of years, and our colleagues previously have been driving this important role really. The designated person, as Bernie explained, is that key contact person, the person that kind of is the liaison with the clinical teams in setting up the meetings for the open disclosure, being that touch point for the patient and their family, providing that ongoing communication and so forth. And they're just invaluable, and something I think within the health service we really need to prioritize with the many competing priorities that we're trying to deliver on. The principal health practitioner, so this is kind of lead person who would generally take a lead on the open disclosure. So this could be a GP in the community setting, it could be the patient's lead consultant, specifically referencing the Patient Safety Act as well. It might be for one of the Category 2 incidents, it might be the CNM on a ward or a chief social worker. So we've explained that role in particular, but they would take a lead on the actual conversation of the open disclosure. Another role that Dr. Colin Henry touched on earlier is around the open disclosure clinical and managerial champions. So this is a new role that has been introduced as part of the National Open Disclosure Framework, and they are particularly key thinking in that Department of Health framework was developed, was that these are really the kind of peer support, those champions who are role modeling open disclosure within an organization. So the intention was very much that it would be a senior clinician, but it's obviously recognized that in some settings there might not be actual clinicians working, and then it might be a managerial champion. They would be somebody that other colleagues could go to for support if they want to discuss a particular incident, ask for that kind of moral support for themselves, and that even will champion the policy and training within the organization. So we have a bit of work to do in that space, but again, really seen as an invaluable role. We have been very fortunate in the HSE and wider health service that we have a fantastic network of open disclosure leads and fantastic cohort of open disclosure trainers. So we're in the national team are a very small team, to be fair, and actually the drive for open disclosure and implementation is being very much led by those colleagues within their organizations and their local senior leadership teams. Now, one of the key things that it is relatively new is obviously there's some new roles introduced through Sláinte Care, and that we've tried to reference that throughout the policy, but is that annual reporting requirement around open disclosure. This year was the first year that we had to submit a report to the Minister for Health on our kind of compliance and open disclosure, looking at our training compliance, please everybody do your training, looking at what kind of supports we have available for our staff in the system, and how many champions do we have recruited at the moment, and so forth. So this year was the first time we had to do that report that was submitted to the Minister for Health. We have over the years already done an annual report in open disclosure, which we've always published. But this chapter really just speaks to that reporting requirement and the kind of layers of governance that each health service and social care service needs to go through. And then eventually there is a collated HSE Open Disclosure report that's submitted, and we will be publishing this year's one on our website very soon as well. Next slide. So in particular, incidents that trigger open disclosure, I suppose, in a short sense, and again, these slides will be available to you as well. We obviously know that open disclosure is very specific to patient safety incidents. Patient Safety Act has introduced this subset of incidents called notifiable incidents, where it's legally mandated to open disclosure, to do open disclosure and to report them to the relevant regulator. Some of you will be familiar with the language that we use in the incident management framework around categorizing different incidents, and Bernie touched on it earlier already. So in particular, where there was harm, we should do open disclosure. So that's not really a change from the previous policy. So the previous policy would have always spoken around doing formal open disclosure for Category 2 incidents and Category 1 incidents, so where there was moderate harm or severe harm and the death. And then now the new requirement is the notifiable incidents. Where there was minor harm, we say, we would still ask you to do open disclosure. It might be a bedside conversation, really nurturing those principles of openness and transparency. Where there's no harm or there's a near miss, it's almost discretionary. And the key consideration is, in particular, where there was no harm, did it involve a patient? Is there a particular risk? So how do we empower patients by talking to them about particular incidents? But it's very much recognized that it wouldn't be practicable to do open disclosure for every no harm instance and every near miss instance. So very much trusting our staff in terms of making that determination. Okay. And then we've had this some some scenarios, and very rare and complex scenarios where there's incidents or potential incidents or particular incidents, patient safety incidents, where it's not known whether there was any patient harm. And we've given some more guidance within the policy in terms of how to approach those. Okay. Next slide, please. Section 5. So we think, look, it is a comprehensive policy. We've captured all the requirements set out within the HSE, but there will be particular chapters that will be very relevant to our staff, in particular Section 5, which very much talks around the process for open disclosure for those Category 2 incidents, Category 1 incidents, and notifiable incidents. We've tried to outline throughout, the ask is very much to try and standardize it as best as we can so that there wouldn't be any kind of confusion for staff in terms of process. We've highlighted with an exclamation mark when there are very specific legal requirements that our staff need to know about. So we very much talk about this open disclosure process for those types of incidents, which is really a 5-step process. And this very much talks about preparation for open disclosure. And we know from our own experience and from feedback that our staff have had a chance to kind of prepare for the open disclosure meeting, that helps the staff really make sure that they kind of anticipate some of the questions that they may get asked so that they can seek the information before the open disclosure meeting. For Category 1 incidents and notifiable incidents, there's a requirement for a designated person, and even for Category 2 incidents, there should be some kind of support contact person within a service. Okay. Then the actual open disclosure, again, it's very much set out in the policy, the kind of key requirements that you should be covering as part of that open disclosure. We would say they are key requirements that clinicians, staff would cover off in any case, possibly without being prompted, as much as talking about an introduction, explaining the incident, what you know at that time. Is there any harm that you know of at that time? What's the organization? How are they going to, what's the treatment going to be for the patients? And is there any learning at any point? So some very, things that you would be covering off in any case. So in our policy, we're quite clear that there should be an apology given as part of the open disclosure. We hear it, there's a lot of research as well from patients and their family. What they often seek is an acknowledgement from organizations that there was a patient safety incident and that they receive an apology. And that brings in that kind of humanity within those conversations as well. We hear feedback that we're very good at communication with patients and their families, but it's really important as well that we acknowledge that there was a patient safety incident and that we apologize in that context. So one of the key aspects, I suppose, one of the changes, and we put through the consultation process as well. So previously there was an ask in the policy around minutes being shared after the open disclosure meeting and conversation. We've adapted that to cover the kind of key points, the salient points discussed at the open disclosure in a compassionate letter. And of course, there should be that requirement of ongoing communication with those types of incidents. We've tried to align it again and removed any references to deferrals. So previously there was some kind of section within the policy around deferring open disclosure. But really, if there's a patient, there's always a relevant person that you can speak to as well and do the open disclosure. And there are 2 scenarios when open disclosure might not occur. So one scenario would be where the patient or the family declines open disclosure at that time. They might just not be in that headspace at that time, and we need to support them and their wishes, and need to be respectful of that, and that is okay. You know, a key piece for us is around documenting that and being very clear that they've had the offer. There's not a pressure on our staff to constantly chase that up, but there should be some kind of follow-up and it should be documented. But very much that the patient or the family, they should be empowered to do that. Know who to contact when they seek that. And then there are the scenarios where we actually can't contact a particular person. We just don't have maybe contact details for next of kin. Certainly I've had that experience previously in trying to do open disclosure. And again, what's required of us is that we make reasonable efforts to identify the person, the relevant person, or the patient. It's generally the relevant person in that scenario. And again, that we document that. As I mentioned, it highlights the importance of the role of the designated person. And we've really tried to emphasize how important it is that teams and staff support one another during the incident management process and the open disclosure requirements. So in our complex healthcare settings, it's very rare that a particular incident occurs just in one setting, or that patients just it's just involved one team. So the best approach, not just for the healthcare staff, but even for the patients, is when specialties are coming together and plan for this open disclosure collectively and support one another. We often hear this as well, but often isn't probably the right word, but even our ambulance services and things like that, if there are incidents that involve different services, collaborate and aim to meet the needs of the patient, really, so that they get a rounded story of what has happened. And again, obviously, it gives both teams and parties the opportunity to hear from the patient and their family as well, so that they get a rounded story from their perspective. We've obviously emphasized the need around record keeping and documentation, and set that out in the policy again. That's a key bit. Everybody, I think, would be quite aware of that requirement. But again, we know that our staff are very good at doing open disclosure, and sometimes the documentation that maybe lets us down actually then, and it's really intended to keep you safe as well as healthcare staff, and to capture those conversations. Next slide. As we mentioned, we have put a lot of emphasis on supporting patients, their families and staff. We know that open disclosure is a key vehicle for that kind of relationship, a relational piece, to rebuild that trust. We know people have been hurt. We know that that's patient, their family and our staff, and we really need to support all parties affected. We have a number of excellent tools, and I suppose this chapter really draws attention to that again. So in particular for patients, the designated person is key, but even the National Patient Advocacy Services, and that signposting them to those services very early on really empowers the patient and their family. And then for our staff, we just find some of our tools, the Assist Me model, for debriefing, if you are a line manager with your staff following an incident, is so important, and something that we should all aim to achieve. Next slide. And then, as per the requirements of the PPPG, we very much captured the requirements of the policy development. A lot of focus is on assurance. So we know, we have a sense that there has been a significant culture shift within the organization. Open disclosure is at the tip of everyone's tongue when there is an incident. And it's really about capturing that and actually recognizing where supports are needed, and helping services to drive improvements in those areas. We know we have a lot of champions and key staff who are really just excelling in this area. And again, it's to recognize excellence and learning from those areas. And that's what that kind of assurance piece gives us an opportunity for as well. Next slide. To help you and take the policy away, obviously there will be some reading to do. We have a number of resources. There's a policy implementation checklist, which I know our team are been very busy trying to get it on the website. So I'm sure if it's not on there right this minute, it will be by the end of the day. And our gratitude to HSE Digital, who are supporting us with that. So we have the implementation checklist, which you can use within your service to kind of test yourselves, to plan ahead for the implementation. We've said in the policy there should be about a 6-month lead-in time for the implementation. Now, obviously, Patient Safety Act has commenced, it's gone live, so those legal requirements already apply. But there might be some areas that you still need to think about to help you with implementing the policy. So that checklist is available for you. Next slide. To help you raise awareness within your organization, within your GP practice, within your teams, within the community setting, residential care, mental health facility. I'm sure screening services. I'm hesitant to leave anybody out. We have a couple of posters as well that you can use. So there's an open disclosure policy launch poster and a flyer as well, just summarizing some of the key changes within the policy. So they are available on our website pages as well. So some of the final pieces that we are just finalizing this week, and they will be up on the website as well. We have, our staff have always found the quick reference guide a very user-friendly tool, because policy, as we know, can be somewhat dense. The quick reference guides really takes some of our busy staff who might encounter in a patient safety incident to those kind of key points in terms of what are the different process steps, what do you need to think about as part of the open disclosure conversation. Just even talking about what does it mean to apologize, what is an apology, and that. So that will be up on our website as well. The patient information leaflet. We do want to do quite a bit of work on the role of the clinical champion, and we'll be engaging with services around that again. Supports for the role of the designated person, and the e-learning programs as well will reflect the updates of the policy. So as ever, you'll hopefully all be familiar with the e-learning program module 1, communicating effectively through open disclosure. We know that's mandated throughout the organization, and we're very pleased to see actually a very high compliance rate with that, which is very encouraging. And then the e-learning program module 2, open disclosure, applying principles to practice. That's in particular for our staff who might be involved in leading out on the open disclosure conversation, any kind of managers or QPS colleagues, quality and patient safety colleagues who might be taking a leading role with regards to that. And we do have face-to-face skills workshops as well. And as I said, a vast network of open disclosure trainers who you can identify for your area of work or region by looking at the open disclosure leads on our website page as well. For any of our training courses, there are CPD points attached to it, and we will be sending you out an email with a survey and an opportunity for you to give us some feedback. We look forward to engaging with you further on the policy. Please reach out to us if you want to have any further conversations, or if you want us to engage with your particular organisation on some of the details around the policy. And as I said earlier, thank you so much for joining the webinar today. Thank you so much to our ISL interpreters today for being with us. Thank you from me to the Open Disclosure team. Have done fantastic work. There've been significant changes over the last little while, so they've really have done a phenomenal amount of work in the background and in the forefront, and really planning the whole organisation. So particular thanks to Mary, who's not with us today, Mary Friel, Kelly McDyer, Ellie Southgate, Roisin Egginton, and been real champions in that space, and all those colleagues who really started off the open disclosure journey from before within the HSE as well. A big thank you to Orla and to Colin for being here and really being significant leaders in this area, and I suppose bringing open disclosure to the agenda of our senior leaders and in the clinical forums as well. Huge thank you to Bernie and Patients for Patient Safety Ireland, who are always very supportive and challenging us in the right way as well, to do the right thing for patients and service users. Thank you to the members of the National Open Disclosure Steering Committee, who have gone through the policy with a fine-tooth comb a number of times, and again, given so generously to their knowledge, experience, which we've tried to incorporate within the policy. Thank you to everyone who contributed as part of the consultation process, external agencies, unions, various different groups of people who provided feedback on the policy. And thank you again to the wider NQPS team for helping with the promotion of today's webinar and the different pieces of work. And thank you to you for joining. And I probably feel like I'm at the Oscars if I keep going at this rate. But wishing you a lovely rest of the day, and we look forward to engaging with you about the policy. Take care. I'm still here.